Namaste and warm greetings to everyone. Every knee tells a different pain story. Our job is to read it before we block it. Before I begin, I declare no conflict of interest. The only bias I carry today is towards better analgesia, safer mobilization, and better recovery. Today, I am going to discuss the regional anesthesia strategy for knee surgery. Let's better understand the basic of regional anesthesia and strategy before moving on to the knee surgery. Traditionally, regional anesthesia was viewed as a temporary interruption of nerve conduction. However, today we must view it as a pain pathway modulation, functional preservation, opioid sparing care, and ERA support. Before defining any strategy, we must first define the goal. A SMART goal provides direction for the entire strategy, not only pain relief but also mobility, safety, recovery, patient satisfaction, and overall outcome. The same surgery may need different RA plans depending on what we want to achieve. Once the team agrees on common goals, analgesia, early mobilization, opioid sparing care, and ERAS recovery, the strategy becomes much clearer. The base RA plan relieves pain while protecting function and accelerating rehabilitation. In TKR, strategic RA should provide analgesia, enable mobilization, preserve cordyceps, reduce opioids, prevent rebound pain, and improve satisfaction. So the target is not simply a numb limb. The target is comfortable, confident, and moving patient. A strategy is never a random choice. It is a deliberate, goal-oriented plan that combines knowledge, resources, timing, teamwork, and adaptability. Strategy is not a single action. It is a structured way of thinking before acting, as depicted in Mintzberg classic 5 model of strategy, consisting of plan, ploy, pattern, position, and perspective. In regional anesthesia, we can translate this business strategy concept into clinical 5P model, that is patient, procedure, pain profile, people, and place. Because the final block choice depends on all five. When all five P's align, outcomes improve. Knee regional anesthesia cannot be standardized because every case begins with two questions. Who is the patient and what surgery is being performed? A child with instability, a young athlete with ACL injury, an active adult with cartilage disease, a middle-aged patient with degeneration, and an elderly patient with osteoarthritis or fracture all have different priorities. Patient factors such as chronic pain, frailty, restricted mobility, dependency, expectations, and rehabilitation potential modify the RA plan. Then, the surgery defines the pain map. Arthroscopic produces portal site and procedure-specific pain. Arthroplasty creates broader and complex pain involving capsule, bones, and extraarticular tissues, whereas the trauma or extensor surgery adds several tissue and periosteal pain, while percutaneous surgery is usually localized and short duration. So, among first two P's, patient profile sets the priority, and the surgical category defines the pain territory. Now, let's see how this translates into strategy. Surgery is the correction of existing pathology, but the creation of new iatrogenic injury, which is nothing but the surgical dissection. Therefore, our analgesic plan must address both the old pain in the patient that brings to the surgery and the new pain created by the surgery. That is why different knee surgery need different strategies. Minor arthroscopic need focused analgesia. Sports surgery needs motor sparing recovery. Orthoplasty needs global rehab friendly analgesia, and trauma may need stronger pain control even if mobilization is protected. PKR is considered as one of the most successful and life changing surgeries because it can transform deformity, disability, pain, and dependence into mobility, confidence, and independence. And after correction, their quality of life changes dramatically. As an anesthesiologist, our role is to support this transition by making the perioperative journey pain-free, function-friendly, and recovery-focused. To do that, we must first understand the basic surgical steps and pain generators of this life-changing procedure. Among various approaches to the knee joint, the medial parapatellar approach is most commonly used. Midline approaches are often used for revision or patellar surgery, while lateral approaches may be required for severe valgus deformity. This matters because severe valgus correction carries a higher risk of common peroneal nerve injury and post-operative foot drop. Therefore, blocks that may involve sciatic or common peroneal components should be used cautiously or avoided. So, before planning regional anesthesia, always look at the X-ray and understand whether knee is varus or valgus, or whether the surgeon is likely to use medial or lateral approach. A block that works well for one approach may not cover the pain signature of another. After incision, pain comes from the extraarticular dissection and intraarticular dissection. Knowing which pain generating structures are removed, retained, or newly injured help us design a truly procedure specific analgesic plan. Different approaches disturb different tissues. Different tissues create different pain signatures, and innervation mapping helps us to predict both coverage and missing territory. Once we understand the procedure, the next P is pain profile, the foundation of strategy. The mechanism, pattern, pain generator, and neural pathway tell us what needs to be blocked, masked, treated, or rescued. Pain begins at the periphery but processed centrally through nociception, spinal transmission, central perception, and descending modulation. That is why chronic pain, sensitization, psychology, deformity, opioid, and expectation can amplify post-operative pain beyond the surgical injury. Therefore, knee surgery pain is multifactorial. It has a superficial and deep component, extraarticular and intraarticular components, mechanical, inflammatory, and neuropathic elements. It can be anterior, posterior, medial, lateral, or global. Even anesthesia and surgical choices matter. General anesthesia, neuraxial, RA combinations, Tunica use, patellar resurfacing, implant type, soft tissue balancing, drains, and physiotherapy can all reshape the final pain experience. If you understand the pain profile clearly, block selection becomes logical rather than habitual. Pain management has evolved from reactive treatment to planned, preventive, multimodal care, and modern vision anesthesia must be integral part of that evolution. No single drug and no single block can address all pain mechanisms. Multifactorial pain needs multimodal analgesia, combining pharmacological agents, non-pharmacological measures, psychological support, and regional anesthesia. Each components work at a different level of pain pathway, creating additive and synergistic analgesia while reducing the side effects. If we reduce the pain signal early through preemptive and multimodal care, we can reduce postoperative hyperalgesia and later amplification. Reassurance, expected setting, and confidence are also powerful analgesic tools because fear can amplify pain. Unrelieved pain can affect heart, lung, gut, wound healing, sleep, psychology, rehabilitation, and lead to chronic pain transition. Pain is not just a symptom, it is a systemic stressor. So our goal is to interrupt the pain cycle early. The next P is people, the team behind the block. Digital anesthesia success depends on alignment between surgeon, anesthesiologist, physiotherapist, nurses, acute pain team, patient, and family. The surgeon defines the pain map through incision, approach, tourniquet, tissue handling, and surgical complexity, whereas regional anesthesia team predicts the gap and design the block, timing, dose, and rescue plan. A good blockist perform a block, but a strategist coordinates the team and anticipates where analgesia may fail. The last P is place, the real system in which our strategy must work. Ultrasound quality, equipment, drugs, monitoring times, block room logistics, protocols, ward support, and rescue resources decide what can be done safely and reproducibly. If only PLS is available and ultrasound is not accessible, choices become limited. Like femoral nerve block, obturator nerve block, static nerve block may be possible, but precision, spread control, and era suitability are compromised. So place decides the practicality. The best regional anesthesia strategy is not the textbook ideal, but the one supported by your working environment. So far, we have completed the 5 P. This tells us what patient needs, what the surgery will create, and what our system can safely support. But before supporting the block, this plan must pass through the 3 F filter: familiar anatomy, feasible technique, and favorable spread. In simple words, know what must be covered, choose what can be done safely and predict where the local anesthetic will actually go. Thus, the 5 P's define the need and the 3 F's decide whether our block can truly deliver. Let us now unfold the 3 F's by connecting three essentials: relevant anatomy, chronoanatomy, and expected local anesthetic spread pattern in the thigh. Knee innervation has anterior and posterior components. The anterior knee is supplied by the branches of the lumbar plexus, whereas posterior knee is supplied by the branches of the sacral plexus. Before supplying the knee joint, these now form three different plexuses. Subsartorial plexus lying on the medial aspect, supplying anteromedial knee and anterior joint capsule. Peripatellar plexus lying anteriorly, supplying skin around the patella and anterior joint capsule. Popliteal plexus lying posteriorly, supplying all intraarticular structures and posterior capsule. The dermatomal and osteotomal innervation comes from the branches of the lumbar plexus anteriorly and sacral plexus posteriorly. Notably, the anterior capsule of the knee joint is weakly innervated compared to the posterior capsule by articular or genicular branches that arise from the terminal branches of the plexus. Proficiency in administering blocks that target all pertinent nerves supplying the knee joint relies heavily on a comprehensive understanding of two crucial anatomical landmarks within the thigh: femoral triangle and adductor canal, separated by the apex of the femoral triangle, which is the intersection point of medial borders of sartorius and medial border of adductor longus muscle. Femoral triangle is the triangular subfacial space below the inguinal ligament, whereas the adductor canal is a triangular musculoaponeurotic tunnel encompassed by two muscles and one aponeurosis extending from the apex of the femoral triangle above to the adductor hiatus below. Femoral triangle is a conical subfacial space that continues into the musculoaponeurotic tunnel, leading posteriorly to the diamond-shaped popliteal fossa. This unique anatomical arrangement creates a visual impression of funnel leading into the tunnel within the thigh. Therefore, adductor canal serves as a passageway for the structure that moves between the front and the back of the thigh. The adductor canal consists of three foramina. The femoral vessels and the saphenous nerve enter the adductor canal through the superior foramen. The saphenous nerve and the descending genicular vessel exit the adductor canal through the anterior foramen, piercing the vasculoadductor membrane. Finally, the femoral vessels exit the adductor canal via inferior foramen, also called the adductor hiatus, to become the popliteal vessel. The nerve to vastus medalis lies outside the adductor canal above the VAM in a separate facial sleeve. These diverse anatomical connections divide the adductor canal into the proximal, middle, and distal adductor canal. Available literature exhibits discrepancy in defining and describing the femoral triangle and adductor canal, creating a perplexing scenario reminiscent of a triangle and tunnel of confusion. Despite numerous studies, a consensus on adductor canal block terminology remains elusive, impacting patient care. How does that matter to us? Wrong is wrong, even if everyone is doing it, and right is right, even if no one is doing it. The block level isn't just a technicality, they are the essence of patient care. Lack of precision can significantly affect analgesic efficacy, post-operative mobilization, and motor sparing effect. Initially believed to be adductor canal block at the mid-thigh, later found to be femoral triangle block, leading to incorrect attribution and credit to the adductor canal block. Despite clear landmarks, misplacement persists, blurring the line between adductor canal block and femoral triangle block. Only a handful studies follow the correct nomenclature for the adductor canal block, leading to a wide array of techniques and classification. The flaws identified in the previous RCT not only perpetuate misconceptions but also cast doubt on the interpretation of all future meta-analyses, leading to the dissemination of inaccurate information once more. So, what's the solution? Standardized nomenclature and technique description nullifying all previous faulty techniques. Preference of ultrasound guidance over surface landmarks to decide the territories of femoral triangle and adductor canal based on precise sonolocation of the apex of the femoral triangle. Let's explore how it can be done. After holding the probe over the mid-thigh, the medial borders of the sartorius and adductor longus muscles are identified. Mark the point on the medial border of both muscles. Draw an imaginary line from the mark point of the sartorius. If the point on the adductor longus muscle lies outside this line, it is the region of the femoral triangle, where the saphenous nerve and nerve to vastus medalis are separated by vasofemoral fascia. If both mark points come on the line, it is the apex of the femoral triangle, which appears as a sign of T, also called as kissing sign. Suppose a point on the adductor longus lies within the imaginary line. In that case, it is the adductor canal, in which vascular membrane can be seen beneath the sartorius, separating the nerve to vastus medalis outside the adductor canal from the saphenous nerve inside the adductor canal. Upon moving the probe from proximal to distal thigh, starting from the inguinal region up to the medial side of the knee joint, the sono-anatomical pattern changes due to varied anatomical interrelationship between muscles and the neurovascular bundle. While exploring different regions, the goal is to identify the apex of the femoral triangle, which is crucial sono-anatomical landmark to demarcate territories of the femoral triangle above and the adductor canal below. As the sartorius muscle serves as a common landmark under the ultrasound guidance, the region beneath the muscle in this area is appropriately termed as subsartorial area. Thus, the femoral triangle and adductor canal block can be considered variant of subsartorial block. The femoral triangle block can be administered specifically in the distal femoral triangle region just above the apex of the femoral triangle. The presence of VAM is peculiarity of adductor canal region. VAM is nothing but the thickened fibrous connective tissue forming the medial border of adductor canal. Due to this, the lower border of sartorius appears bilayered in the adductor canal region. The injection at any point distal to the apex of the femoral triangle below the VAM can be considered an adductor canal block. However, the involvement of neuronal component will be varied at various locations. The adductor canal block can be given at any distance distal to the apex of the femoral triangle. However, we recommend giving this block in the proximal adductor canal area to avoid proximity to the sterile cervical site. Various dye studies in the subsequent year demonstrated the spread of dye in the popliteal area when injected into the adductor canal below the VAM. In contrast, dye injected into the femoral triangle remains confined under the sartorius muscle without reaching the popliteal region. The volume of the drug and injection site significantly influence the extent of the spread into the popliteal region. Injecting 10 ml of drug into the distal adductor canal can involve the popliteal plexus, whereas a higher volume of 15 to 20 ml is required for the proximal adductor canal to achieve the same effect. Moreover, excessive drug volume injected into the true adductor canal may lead to accumulation in the popliteal fossa, initially affecting popliteal plexus, followed by its mother branches such as tibial nerve and common peroneal nerve, and eventually the sciatic nerve, particularly with the volume exceeding 30 ml. Let's explore how this spread occurs. When the drug is injected into the adductor canal below the vascular membrane, it traverses through the adductor hiatus alongside the femoral vessel, which is nothing but the wider gap between the two heads of adductor magnus muscle. Subsequently, the drug enters the popliteal fossa from the medial to the posterior thigh, spreading into the intermuscular plane and eventually affecting the sciatic nerve, depending upon the volume injected. This forms the foundation of novel high volume proximal adductor canal block, HIPAC block, for the below knee surgery, wherein a high volume of diluted local anesthetic is injected into the proximal adductor canal to involve the saphenous nerve directly and sciatic nerve indirectly. So, how to obtain the popliteal plexus coverage? To achieve the popliteal spread, the drug must be injected into the true adductor canal below the VAM within the connective tissue compartment containing femoral vessels and saphenous nerve among the various described compartments of the adductor canal. Additional dye studies have consistently revealed the involvement of nerve to vastus medialis in the distal femoral triangle block but sparing in the adductor canal block. Furthermore, injection of the drug in the distal femoral triangle can also involve medial and intermediate femoral cutaneous nerve and nerve to vastus intermedialis through the limited proximal spread beneath the fascia lata. Before familiarizing LA spread pattern, let's explore the behavior of liquid or fluid when injected into confined spaces, surfaces, or tunnels. When injected into a tubular structure, a liquid naturally disperses evenly, occupying the entire volume of the tube if sufficient volume is available. If the tube is linked to a piston at the top, the fluid introduced into the piston chamber initially fills the lower section of the piston and then progresses into the connected tube. By introducing a partition within the tube, the liquid injected into the piston will be distributed uniformly on both sides of the partition. However, if an obstacle is introduced on one side of the partition, the injected liquid will preferentially distribute more on the unobstructed side due to the path of least resistance. As the liquid fills the tube during the initial injection, subsequent injection into the partition tube will prompt the liquid to flow towards the area of least resistance, typically towards any available vent or opening. If we extrapolate these concepts, we can understand the possible pattern of local anesthetic trade in the femoral triangle and adductor canal region. In volumes less than 10 ml, femoral triangle block can involve saphenous and nerve to access medalis with limited trade in the femoral triangle region. Similarly, a volume less than the actual volume of adductor canal, that is 15 to 20 ml, if deposited in the adductor canal region, can involve only saphenous nerve consistently with unpredictable spread proximally or distally. However, increasing volume in the same adductor canal can also involve the popliteal plexus due to distal spread through the adductor hiatus. Further increasing the volume in the same region can also involve the sciatic nerve posteriorly, which is the basis of many blocks. Dual subarterial block entails two injections administered at two distinct locations, hence termed as dual, beneath the common muscular landmark sartorius, thus designated as subsartorius. The first crucial step of DSB is identifying the apex of the femoral triangle. Next comes the strategic deposition of local anesthetic solution into the distal femoral triangle and proximal adductor canal, lying thus proximal and distal to the apex of the femoral triangle. The first injection of DSB in the distal femoral triangle directly targets the saphenous nerve and nerve to access medalis. The initial injection volume primarily occupies the distal femoral triangle area. Consequently, some portion of the drug disperses proximally within the femoral triangle, while another fraction enters the adductor canal alongside the femoral vessel. The majority of the drug flows towards the area of least resistance, progressing distally beneath the sartorius but above the VAM. Spread within the femoral triangle region directly involves the saphenous nerve and nerve to access medalis along with medial portion of peripatellar plexus due to the proximal dispersion, whereas distal spread above the VAM involves the subsartorial plexus. During the second injection of DSB, the spread pattern of the first injection can be visualized under the ultrasound. The remaining volume of the adductor canal is predominantly filled by the delivering local anesthetic perivascularly beneath the VAM. Any excess volume subsequently passes through the adductor hiatus, extending into the popliteal region to involve the popliteal plexus. When both injections are given in correct sequence, at the correct location, and with the appropriate volume, their combined spread can target the key procedure-specific innervations required for the TKR analgesia. This proposed spread pattern, including involvement of relevant neural components, was observed in our cadaveric study and is supported by our clinical volume comparison study and RCT. In our RCT, DSB showed a superior analgesic profile compared to femoral triangle block or adductor canal block alone, while maintaining a non-inferior motor sparing effect. Clinically, this spread can produce sensory coverage over the anteromedial knee, medial retinacular complex, tibial tuberosity region, and intra-articular therapy. However, it may spare the anterolateral scheme supplied by the lateral peripatellar plexus and the posterior scheme supplied by the posterior femoral cutaneous nerve. So, DSB is not just two injections, it is a sequence-based spread guided strategy designed to match the dominant pain generator after total knee replacement. After understanding the 5 P's and 3 F's, we can finally customize the RA option rather than choosing it randomly. Knee regional anesthesia is like an analgesic buffet where all options are available, but the right plate must match the patient, procedure, pain pattern, and resources. RA options for the knee surgery range from center to periphery, including neuraxial block, plexus block, individual nerve block, region-wise block, and most peripheral blocks around the knee joint. Neuraxial block and blocks near the neuraxis are considered non-era suitable due to their motor involvement and are mainly used for the anesthesia purpose. However, distal blocks are considered era suitable and motor sparing. As we move from center to periphery, motor involvement and complications generally reduce, while precision, procedure specificity, local anesthetic volume, and number of injections increase. So, the question is not which block is best, but which strategy best balances analgesia, motor preservation, duration, complexity, and recovery. Each option has strengths and limitations. These techniques are tools, not competitors. So now that the menu is clear, let us see how any regional anesthesia technique can make procedure specific, motor sparing, and longer lasting to reduce opioid consumption. To select a procedure specific block, I use simple approach: identify, select, and combine. Identify the procedure specific pain generators and their innervation. Select the block that targets them best and combine techniques when one block cannot cover the full pain map. Notably, the pain generating components differ before and after surgery. Preoperatively, intraarticular components dominate pain generation due to inflammation from the osteoarthritic changes in the joint. However, after totally replacement, all intraarticular pain generating components are excised and replaced with non-neural, non-vascular implants. Thus, postoperatively, extra-articular components over the anteromedial cervical dissection area, which were healthy before surgery, generate more pain than intra-articular components. However, the pain-generating components of arthroscopic knee surgery are mainly intra-articular, requiring similar analgesic coverage. So, the same knee needs different analgesic thinking before and after surgery. Procedure specific regional anesthesia means matching the block to the pain generation, not matching the patient to our favorite block. Among all RA options from center to periphery for PKR, the analgesic coverage of each motor sparing and era suitable regional anesthesia technique differ. By involving anterior and posterior pain generators, analgesic coverage of DSB appears more procedure specific than other available options. Let's understand how to make the block motor sparing. The name of the block does not guarantee motor sparing. It is created by design. It starts with selective targeting, preferably terminal sensory or articular branches, rather than blocking the parent nerve proximally. Because parent nerves also give motor branches that maintain strength and function. It also depends on how we use local anesthesia. Diluted concentration preferentially block pain carrying sensory fibers while reducing dense proprioceptive and motor blockage. This matters because local anesthetic diffusion from outer mental fibers to deep core fibers is concentration dependent. Higher concentration increases deeper motor involvement while diluted LA helps preserve function. The volume also should be optimal, enough to cover required pain generators but not excessive enough to straight into the unwanted motor compartment. So, a true motor sparing block needs the right target, precise injection level, dilute concentration, optimal volume, suitable local anesthetic such as bupivacaine or levobupivacaine, predictable spread, and planning according to the patient's mobility goal. How to prolong the block duration? And when we think of prolonging block duration, we often focus on local anesthetic dose or adjuvant. But sustained analgesia is not just about adding more drug. It is about reducing the ongoing nociceptive drive from the surgical site. To prolong analgesia, we need the right block for the right pain pathway and long-acting local anesthetic, appropriate adjuvant, early multimodal analgesia, and measures to reduce inflammation, swelling, and tissue irritation. Most importantly, we must treat the pain generator itself. If inflammation, swelling, and tissue tension continues, nerves keep firing, sodium channels open, and block seems to fade earlier. A longer block is not simply more local anesthetic, it is less nociception. So don't just block the nerve, silence the pain generator. Now let us connect each block with the pain generator it can realistically cover. For extra-articular anterior knee pain, femoral nerve block gives broad anterior analgesia but at the cost of more quadriceps involvement, while femoral triangle block gives more procedure-specific anterior and anteromedial coverage with better motor sparing intent. For intra-articular and peri-articular pain, adductor canal block with adequate volume or IPAC block or popliteal fossa block may help depending on the injection site, volume and spread. Posterior knee pain needs separate planning because anterior block alone may leave this territory untreated. When one block cannot cover full pain map, combination strategies become important, such as DSB for procedure-specific TKR analgesia, femoral nerve block plus adductor canal block for selected revision TKR, femoral triangle block plus IPAC or popliteal fossa block for broader coverage, and adductor canal block with cutaneous block or ring block when superficial incision pain dominates. Therefore, map the pain generator first, then match the block or combination. Once we have selected and implemented our strategy, if the patient still develops pain, we should not see it only as a failure. We should use it as a feedback. First, map the pain carefully because the exact painful area tells us which generator is still active and which neural territory has been spared. Pain mapping guides rescue analgesia logically. At the same time, this becomes a learning point to refine our future techniques that involve target, level, volume, spread, and block combination. Rescue analgesia should not be random. Map the pain, identify the gap, rescue the missed territory, and refine the strategy. Because keeping the patient pain free is the ultimate goal. When we compare DSB with other available and most discussed RA techniques, many factors like complete procedure specific analgesia coverage without the requirement of additional RA technique, comparable motor sparing and opioid sparing effects, suitability to the ERAS protocol, and anesthetic administered technique without any reported fatal side effects like last in DIA, DSB outweighs all available RA techniques. However, despite its novelty and relatively limited research, DSB warrants further discussion, studies, and evidence to establish its full potential. To summarize, knee regional anesthesia should be loco-regional, procedure-specific, motor sparing, opioid sparing, multimodal analgesia for multifactorial pain. The pain control should not start inside the operation theatre and should not end at discharge. It should run as a continuum from prehab to rehab. Regional anesthesia has a role at every step, reducing nociceptive load, supporting early mobilization, smoothing discharge, and possibly reducing the transition from acute surgical pain to persistent pain. As consistent pain control at every step breaks the pain cycle. My practical takeaway is simple. Do not jump directly to the block. First, assess the context using 5P, patient, procedure, pain profile, people, and place. Then filter the plan through 3F, familiar anatomy, feasible technique, and favorable spread. Only after that, choose the final block combination that provides analgesia, preserves mobility, maintains safety, supports recovery, and keeps a rescue plan ready. So always remember, block is only the technique. The strategy is the thinking behind it. After the 5 P's and 3 F's, this is how strategy becomes the practical protocol. Phase-wise multimodal analgesia from pre-operative preparation to post-operative recovery. This protocol represents the endpoint of whole talk. Strategy covered into a reproducible, patient-centered, recovery-focused analgesia path. Thank you so much for listening. I hope this session changes the way we think from isolated blocks to intelligent RA strategies.